Welcome to Heart Failure Minutes. Today I'm delighted to speak with Professor Michael Givertz, Professor of Medicine at Harvard Medical School, Director of Heart Transplant and Mechanical Circulatory Support Program at Brigham and Women's Hospital, and the incoming President of the Heart Failure Society of America. Hello, Professor Givertz. Thank you very much for joining us today. We will focus on the ongoing challenges and emerging innovations in advanced heart failure. So, Professor Givertz, when we think about advanced heart failure today, how is decision-making evolving between transplantation and durable mechanical circulatory support? Where do you see the field heading?
Well, Milica, thank you so much for inviting me to join you here for the Heart Failure Minutes. It's really a pleasure to have an opportunity to talk about this area that I'm pretty passionate about. It's really an exciting time to be part of our field in advanced heart failure and transplant cardiology. But we have some serious challenges, but also some opportunities in the field. So to really come back to your question, I would say first and foremost, we need to do better at identifying patients who are well along in their heart failure journey. I think we have become so good at offering guideline-directed medical therapy and device-based therapies, as well as ambulatory monitoring for our patients, that we sometimes continue to miss patients as they begin to slide from stage C to D, and frankly even in stage D heart failure. So first and foremost, we need to be able to identify those patients who can benefit from our therapies. Secondly, I think we need to become increasingly sophisticated in the way we think about life-prolonging therapies for our patients with advanced heart disease. I don't believe that in the current era it's okay simply to offer a patient, let's say, the choice between a durable VAD and a heart transplant. Rather, we need to think about the lifelong of care of our patients. So for example, for a younger adult, it might be more appropriate to start with a durable VAD, live for 5 or 10 years of good quality of life, maybe raising children, working, and then to transition to a heart transplant and live another 10, 20, or even 30 years. There may be younger adults, for example, with non-ischemic heart failure, shorter duration, and we need to not forget about the fact that durable LVADs can sometimes be used as bridge to recovery. We sometimes forget about that, and while there are a few programs who are focused on that, many are not. And then lastly, I would say an area that is of increasing excitement to me and others in the field, but is also a challenge, is how the types of donors that we're hearing about and the recipients that we take care of had evolved over the last several years. They become more complex, and so the management around taking a sick patient through, for example, transplant, matching them with the best donor, and then optimizing outcomes requires really an interdisciplinary team-based approach to care.
Thank you very much for this answer. Despite remarkable technological progress, implementation of advanced therapies remains uneven. What are the key barriers to deployment of transplant and mechanical circulatory support therapies today?
Well, I'm really glad you asked that question. I would say one of the bedrock principles of what we do in our field is around equity and fairness, particularly in the field of organ transplantation. And I think, if you were to sit in, for example, on one of our multidisciplinary selection committee meetings, you'd really know what I'm talking about. But first and foremost, we need to make sure that we not only identify those patients who are sick enough to be considered for these therapies, but that all patients have potential access. And there are several barriers. First off, not just identifying the patients, but once they get identified, getting them into the system, so access to the care that we can potentially provide. And whether it's due to their insurance networks or their healthcare systems, sometimes there are barriers set up to getting patients to see the providers that they need to see, again, as we always say, at the right time, in the right place. I would say other barriers to really offering these therapies, again, are around the economic pressures of the treatments and really variabilities in the reimbursements that institutions receive. For many, many years, transplantation was always thought to be a growth field. The more numbers of transplants you do, the better it is for the institution. It's not clear that that's the case anymore. And if you try to actually figure out the resources that go into and come out of transplantation, it's very complicated because this is an area of medicine that really runs across divisions and departments and institutes. And so trying to figure out whether this is actually an area of medicine that should be growing or remaining stable, I think, is up to some of our administrative colleagues to sort out. But in the meantime, we're going to do our best to offer therapies to all patients and make sure all of those patients have access to the care that we can provide.
Great points. Thank you very much. In general, there is a concern globally about declining trainee interest in advanced heart failure. From your perspective, why is this happening, and what role can the Heart Failure Society of America play in addressing it?
So again, I'm really happy that you brought this up, because as the incoming president of the Heart Failure Society, we have a very strong interest in making sure we do better here. I don't know, I think you and many others are aware, over the last few years, the numbers of fellowship slots in the field of advanced heart failure transplant cardiology have not all gone filled in our match in this country, and I think there are similar problems around the world, as well as in recruiting really the next generation of providers. Now, why is that? It's a complicated question. When I interview, for example, general cardiology fellows who are coming into our field, I don't necessarily ask them, why are you interested in being a heart failure transplant cardiologist? What I ask them is, how come your colleagues do not want to go into heart failure? And you receive a lot of interesting answers, and it's not one size fits all. So, many of the fellows love what we do. They love the devices that we see, the complex patients that we take care of, the continuity of care that we're able to provide for these patients. But then they say, but you work really hard, maybe harder than many of the other cardiologists that we know. You don't seem to get reimbursed in many areas in the same way, for example, as some of our interventional or electrophysiology colleagues are being reimbursed for their work. So it's that balance between work and life outside of work, and also reimbursement for the work that we do. The other problem is really exposure, right? So if you go around this country and in centers around the world, fellows are quite variably exposed to different areas of cardiology. And so it's that early exposure to the right really mentor, whether it's a clinical mentor or research mentor, that's so important. So we need to do better at making sure that fellows who are interested in our field have the opportunity to work with really the people that they would learn from and really be inspired by. And then the other area I think that's really important is opportunities around research and innovation, right? I mean, many of us are in the field and love this field because it's always changing, we're always innovating. And so in order to train not just the next generation of outstanding clinicians, but clinical investigators and basic investigators and translational researchers, we need to give those fellows the opportunity to meet with and train with those people. So we have a lot of work to do. I will say the Heart Failure Society has a couple of initiatives that are really focused on this. One is our device-based initiative, but one is actually a workforce initiative, which really has two agendas. One is focused on you and myself, those of us in the field, making sure that they advocate for making sure our quality of life is improved, and frankly, we're reimbursed for the work that we put in. And the second part of the initiative for the society is really focused on our trainees, making sure that they have those opportunities to work with the best people and to really have an opportunity, if they're interested in devices or critical care or end-of-life care, that they have the opportunities to learn in those areas and make that critical decision about going into our field.
Professor Givertz, thank you very much for sharing your perspective. Today's discussion highlights that the future of advanced heart failure will depend not only on innovation in transplantation and mechanical circulatory support, but also on earlier decision-making, stronger care systems, and renewed investment in training the next generation and leaders. This was Heart Failure Minutes. I'm Dr. Milica Vukićević signing off. Until next time. Thank you.